Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMFS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another podcast. Today I'm with Dr. Dean DeLuke. He is an oral and maxillofacial surgeon, professor emeritus, who is living in Virginia. Dean, thank you so much for joining us on the podcast again.
Great to be with you again, Grant.
Yes, it was great to do a couple of podcast interviews with your nephew recently, Dr. DeLuke, the orthodontist. He's an awesome guy and just shed a lot of great light on the kind of the orthodontic relationships with oral surgery when it comes to airway. And then also we did one on finances. So really cool guy. Thanks for that referral.
Yeah, I heard the one on finances and I really enjoyed it. It was a great exchange, probably helpful too, especially some of the younger new to practice docs and residents.
Yep. Yeah, it was great. I think the airway one, by the time this comes out, that one will have already come out. But I kind of have a queue for several weeks, so that one hasn't come out quite yet. But that'll be a great one for our listeners to listen to. Well, good. Today we were hoping to talk a little bit about local anesthesia and some of the nuances there. It's probably not the most glamorous topic, but I think there's a lot still there that we could talk about that probably would be helpful for a lot of our listeners. So yeah, maybe we could just start with some of the pearls and thoughts that you had on this topic.
Yeah, and I'll just preface it by agreeing. I hope your listeners aren't going to tune out and hear local anesthesia because I think there's enough for us to talk about things we haven't maybe thought about in a while. And I'll promise at least a few pearls and a couple new products in the pipeline that would probably be of interest.
That's fantastic. All right. So one of the first questions would be how to anesthetize a full maxillary extraction case. This is an interesting.
Yeah. So, and let's say for sake of discussion that it's naked local, no sedation, and it's going to be a full arch case. So I don't, how would you anesthetize for that case? And I'll give my thoughts.
Yeah, I mean, if usually full maxillary extraction case, it's doing like PSA blocks, infiltrating, with, generally I do lidocaine and then go around towards the end of the case with marcaine. But yeah, infiltrating, a couple blocks, and then some palatal injections. I mean, what would you do?
Yeah, I think so. I'm probably going to do an infraorbital and PSA. Then, of course, we have to worry about the palate. So, are you going to give a greater palatine or pretty good studies out there with septicaine? For a lot of cases, you can get away without palatal anesthesia. I'm probably still going to do it. And then I think have to distinguish again if it's pure local, we tend to be impatient as surgeons, right? We're used to sedation. We want to get that local in pretty quickly, but we don't want patients going back to their referring docs saying, boy, his injections hurt a lot more than yours do. So I think we need to slow down a little bit. So if it's just a segment of the maxilla, I might even just do a posterior infiltration, which you can sneak in there pretty comfortably, and then just slowly work forward into areas that are already numb. But in essence, I'm going to use blocks and minimize the volume by using blocks as opposed to doing a whole lot of infiltration. And then for the anterior palate, how do you deal with that if you want anterior palatal anesthesia?
Yeah, I mean, usually I do the incisive canal or the incisive nerve block there with a 30 gauge needle.
Yeah.
Blue needles what we have, but I mean I'll take the back of my mirror, and press on it first and put pressure and then the injection. It's always painful though. Those are the worst ones.
Yeah, it clearly. And like you said, pressure anesthesia. You can use the 3-point technique. I think Malamud talks about that. So you do a 30 gauge a little bit labially right in the frenum area, and then that'll take effect very quickly. Then you can go through the papilla with that same 30 gauge blanch the palate just a little bit and then go directly into the palate. That's a little bit
Nice.
kinder, takes a little more time, but that 3 point injection, again, if you're dealing with
Yeah,
local without sedation, might be something to think about.
I like that. That's a great idea.
And then
Typically,
I'll just say, I know people, we could probably talk about second division blocks too. I don't do this, but I know a lot, not a lot, but some surgeons who, if they're doing a full arch case, they'll actually do a second division block and just leave it at that. I don't know that it's something that you've done. I think of other pretty definite indications. That's a good one to have in your armamentarium for things like infection, where you can't be sedating a patient for whatever reason. They're not NPO or they're not suitable candidates. You've got a whopping infection. You can't inject locally. Then you can do a second division block, either through the greater palatine foramen, which is the most direct approach, or you can go laterally, get into the pterygopalatine fossa that way, essentially like a high and posterior PSA. That's a little less direct. If you're in that greater palatine foramen and nearly burying the needle, you know you're where you have to be. So we've used that. Residents love to do that. If there's an infection, patient can't be put to sleep for whatever reason, that can be useful. But I started off by saying, I know some that will do that lateral approach and just do, if they're doing a full arch case under sedation, they'll just use that lateral second division block. I don't know, it's a little ambitious, but there are people who do that.
yeah, I'm hesitant to like bury the needle in that PSA region. I did that in dental school, and I gave a lady a hematoma back there, and I think just really hit those pterygoid vessels, those the plexus there, and it was not fun for her. But anyways, I just probably being careful of that type of thing and knowing the anatomy a little better.
Yeah, that's not what I'm going to do. And if I have to do one, I like the approach through the greater palatine foramen much more, using a
Yeah.
25 gauge needle, infiltrate a little first so that you can then, with a 25 gauge, probably pretty safe, putting a bend on that so you can kind of find the foramen, and just, it's kind of interesting to see that needle bury itself up, going up the foramen.
Yep. Real quick question. Do you use topical anesthetics first, or what are your thoughts on that?
I still, again, if you're dealing a patient with naked local, I still use it labially. As we know, on the palate, it's really not that effective. So, like you said, pressure anesthesia with a mirror is more effective.
Yeah, I do topical as well. Even if it's sometimes I feel like more of a placebo and patients, expect it makes them feel better.
Sure.
But I know a lot of surgeons, especially who don't, and don't use it at all. I think there is concern. Recently, too, I was reading that case of a patient who had an allergic reaction to the topical. They were allergic to I think, a red dye, and that was in the like cherry topical. I don't know. So it's something to consider as well, that there is more potential for allergy with those. Anyhow,
Yeah, I haven't seen it, but I'm aware of that as well.
okay. What about articaine? I know there's varying you know, feelings about this and if you should block with it, if it's safe. The literature sometimes suggesting that there could be more risk of nerve injury. What are your thoughts on that?
Yeah, I mean, you can cite things either way. I think it's pretty impressive to me if you look at the FDA adverse reporting, and it's not all that new. I think it was around 2008 or something that came out. The post-injection persistent paresthesia was much greater for the 4% solution, so prilocaine and articaine, as opposed to lidocaine, bupivacaine, or Marcaine, by a factor of like 1 in 2 million for prilocaine to 1 in close to 200 million or more for the other agents. So it's a little hard for me to ignore that. But others will cite, there have been clear studies where they did in vitro studies looking at lidocaine versus articaine on neuronal effects in vitro. There's no difference. So I know Malamud would say, there's no difference, but I find it hard to ignore that FDA reporting. So as far as what we teach in the dental school, we teach not to use articaine for blocks. I'm certainly not here to say yes or no for blocks. I mean, there are lots of people who do that, and I'm not at all critical of that. But medical legally, I will say I've come across cases where experts have said using articaine for a block was a deviation in standard of care and tried to support a lawsuit for that. I don't think it would stick, but there's always that out there too.
Okay. Yeah. I mean, my personal practice is I do blocks with, articaine, septicaine. I know many who do. I've never had any issues. It can be helpful, especially for the, infected abscess patient. It's very difficult to get full anesthesia on. Anyhow. So yeah, I know there's a lot of different opinions on this one.
I agree entirely. No problem using it for a block, in my opinion.
Okay. And then maybe we could touch on just your thoughts on protocols for using local in pregnant patients.
Do you routinely check with the OB if you're going to give local?
I used to. I honestly don't anymore, not routinely. I just found that I was very rare I had any OB saying much, and usually it was a new OB right out of school saying, "Oh, don't use epi." But all the experienced ones were said it's fine and it wasn't an
Yeah.
issue. What are your thoughts?
Same thing with me. I used to do it, and what did they always came back and said, "Yeah, don't use epi." Well, we've got basically four agents that we use a lot, and the two class B, so more favorable ones, are prilocaine and lidocaine, both having epi. So
Yeah.
the mnemonic pregnant lady, PL, prilocaine and lidocaine, as opposed to mepivacaine and articaine, which are class C. Mepivacaine, of course, would be the one without epi. So, if you've got an LB saying that, it's hard to go against it, but they're
Yeah.
thinking, when they think epi, they're thinking of huge volumes, a general surgeon
Yes.
pumping a whole bunch in the OR. If you actually have a discussion and say, we're talking about 18 micrograms in a carpule, oh, well, that's fine. So I don't anymore, and I'll typically use lidocaine with epi.
Fantastic. How about half-lives of the different agents and some of their implications?
Yeah, so I mean, we don't do a lot of long cases, but we do have our full arch extraction with immediate implants. Those tend to go longer, so maybe we need to think about half-lives. Most amids have a half-life somewhere in the area of 90 minutes. So if you've gone, you have one of those marathon cases, you've gone a couple hours and you need to re-inject, I think you're pretty safe putting, even if you've gone to maximums, putting more in at that point. Articaine is different. Articaine has a shorter half-life, 30 to 60 minutes, and that's due to the fact that it's mostly metabolized by plasma pseudocholinesterase, unlike the others, which are metabolized in the liver, excreted in the kidney.
Okay. Have you had any experience yet with Exparel, like lysosomal bupivacaine?
We've used it some, and I'll talk about another new product later, or I could talk about it now. Have you used Exparel?
Just starting to, yeah.
Okay. And do you dilute it like half, or how do you dilute it and prepare it?
Yeah, usually half.
Okay. So I'll give full disclosure here, but I'm going to talk about two products. One is buffered lidocaine. We can get it into that, or buffered amides in general. But there's a product called Enduracaine that's in the pipeline. And the advantage of that is it has a longer shelf life. It has a 2-year shelf life in contradistinction to, the one that we have available now. It'll probably be out there in a year's time. And again, it'll be packaged in a regular carpule, so you'll just pop the carpule into your normal syringe and use it that way. So it'll be a little simpler. And some people do worry about cardiotoxicity with Marcaine. So Enduracaine is essentially, it's tetracaine and lidocaine with epi, and it eliminates the Marcaine, which there's some concern with cardiotoxicity with that.
Got it. Can you comment a little bit on some of the nuances of allergy testing? I'm sure we've all had many patients sit down the chair and say, I'm allergic to Novocaine, or I'm allergic to, the numbing shot, and it's very vague. And have
Yeah.
you been tested? Most of them haven't. What are your thoughts on this one?
Yeah, so I mean, we all know how to get at the patient who had a true reaction or a suspected true reaction. And, those don't come across our practice very often. But, if you do have enough suspicion that you want to have the patient tested, maybe they haven't had suspicion of a severe reaction, they haven't had anything administered since then, So, you have no records to go on, and you're, again, suspicious it was a true reaction. You're going to send the patient to the allergist. There's the whole process is fraught with potential difficulties because, again, we know true ambient allergies are very rare. Many were due to the sulfites in the vasoconstrictor containing locals, or in the older days, carpules used to have methylparaben. They no longer have that in the carpules. But the point is, there's potential for false positives if
Mm.
an allergist tests with lidocaine out of a multi-dose vial that is going to have methylparaben. So you got a potential false positive. Or if you want them tested for a vasoconstrictor containing local, then they have to be exposed one way or another to the sulfite. And we used to, a long time ago, the thinking was, we'll give the patient the carpules, actual carpules for the allergist to use. But then a lot of allergists say, well, I'm not going to use anything with epinephrine because that's going to mask a response. So I guess the bottom line is, I think most contemporary allergists would be savvy to all this, and they don't all agree that epi will mask the response. But I think you need to let them know what you'd like to use. So, you don't want to have them testing from a multi-dose vial, but you do want to have some exposure to sulfites, whether it's directly or whether it's using an actual carpule.
Got it. Okay. Yeah, that's helpful to kind of know how to guide them and have that conversation.
And
How
the other thing, I don't, have you ever used Benadryl in a pinch if you suspected a true allergy? You had a patient that you had to do something for, couldn't get records, you just had enough suspicion that you were to give you pause. Have you ever used Benadryl?
no, not like that.
Yeah. It has some local anesthetic effect. I've used it with the residents, and it has a fair local anesthetic effect. We always say, well, you have to add a little brudicaine to it to really make it work.
Are you injecting the Benadryl locally or what are you
Yes.
doing? Okay.
Yes, it's a local injection.
Got it. Okay. How about what are your comments on the max doses? I mean, there's certainly some confusion out there between, I think, surgeons and their general dental colleagues and others. What are your thoughts on this and how to know what is the quote unquote max dose?
Yeah, I mean, this has always bothered me. In fact, we did a little study at VCU that I could talk about. But if you go back, you have to go back in history a little bit. Malamud, I think, still considered the guru of local anesthesia, and his textbook is the Bible. If you look at his current textbook, he cites maximum MRDs, manufacturers recommended maximum doses, as the maximum doses. So that would be 7 milligrams per kilogram for lidocaine. But if you go back, I think, two textbooks earlier, he actually cites another guideline. There was the Council on Dental Therapeutics that had a lower guideline, which was 4.4 milligrams per kilogram. And
Mhm.
the American Academy of Pediatric Dentistry has adopted that and still considers that the standard. So what do you do? Well, I think for children, you follow the lower guidelines. The fact that you have an official body recommending lower guidelines, it's again a little hard for me to ignore that. I've had the actual discussion with Malamud, and he says no. He takes issue with the American Academy of Pediatric Dentistry saying max guidelines are max guidelines. So it's 7 milligrams per kilogram for lidocaine, not 4.4. It's a little lower for mepivacaine, 6.6 as opposed to 4.4. And that he, draws a hard line on that. So make your own decisions. I would also point to the fact that overdoses do happen. True overdoses are real, and a lot of them occur in the setting of pediatric patients, particularly or especially some of these marathon general dentistry cases under sedation where they're using a large volume of local. Some of those
Mhm.
have led to actual overdoses. So
Okay.
I would still use the lower guidelines for children. And you can get to those pretty quickly. So, I mean, we could look at, let's say you've got a child who is 30 pounds and you're going to use carbocaine. We don't have to go through the calculation, but I'll just say we'll skip through the calculation. You're going to get to the max dose in like a carpule and a half of mepivacaine or carbocaine. Not quite the same if you're using lidocaine or prilocaine.
Yeah, and it seems like I remember studying this, originally in dental school and other settings, but the max dose, it seems like it doesn't really have guidelines as far as time goes, right? So if you have a long case and you're giving some in the beginning, I mean, does max dose just mean total per patient per day? I mean, what's the timing on that?
Well, that's why I think when we talked about half-life, I think if that half-life, given what it is for the amids, if 2 hours have gone by, I mean, I wouldn't give the max dose again, but I think you're safe adding some at that point. Does that make
Right, okay.
sense?
Yeah, that makes sense.
And then again, this always bothered me that there were two standards. So you had the Council on Dental Therapeutics and you had Malamids in his most current text. So we actually did a survey. This was interesting, where we surveyed the people responsible for teaching local anesthesia, pharmacology, and technique in dental schools. And we had a pretty good response. I think we had over 60% of schools responding. And there was no consistency whatsoever in terms of whether they use the higher dosage guidelines or the lower. And the most surprising thing to me was these were people that are responsible for teaching it to dental students, and nearly a third of the people teaching it were not even aware that there were two differing standards. So if anybody's
Wow.
out there and wasn't aware of the fact that there are two standards, don't feel bad, because the people teaching it were not either. So that was really surprising. But basically, there was just no consistency. Some used the higher dose, 7 milligrams for lidocaine, and the lower dose, 4.4 for mepivacaine, which made no sense. No consistency. That was pretty revealing.
Sounds good. I mean, that's another topic, but I mean, have you had a patient with and seen a local overdose, and what did you do about it?
I have not personally. I've reviewed cases where it definitely did happen. Like I said, some of those were pediatric patients in the setting of marathon general dentistry under sedation. And a couple others were elderly patients, probably with undiagnosed liver or kidney disease, where they were, at least if you look at the records, they were below, sub-maximal doses and clear toxic effects from them. So I think, we could talk about metabolism and caution for patients with significant liver or kidney disease.
Hmm.
Maybe since articaine has involvement of plasma pseudocholinesterase as opposed to, primary activity in the liver and kidney, maybe that's a safer choice for those patients.
Yeah, that was another question is, the patient who comes in that's having issues, maybe they're on dialysis, they're having cirrhosis. I mean, what extra precautions and things you do for those patients?
I don't really think there's standard of care issue, but just again, thinking logically, maybe I would personally think about using articaine just because of the variant metabolic pathway.
Okay.
That makes sense.
Yeah, for sure. Um, what are your thoughts on troubleshooting the quote unquote hot tooth? I have frequently run into this just real infected tooth, done multiple carpules, are still feeling it. There's usually some reason why we can't sedate or the patient doesn't want sedation.
Right.
Yeah. What do you go about doing to help these patients?
Yeah. So, I mean, working in a dental school and covering an emergency clinic, that's probably a weekly, if not more common occurrence, where typically I guess most often it's a lower tooth and the student comes up. Hopefully, the student had the foresight to come to the attending, the covering faculty or resident, as the case may be, before they've injected a whole bunch of local. Every once in a while, though, you'll get a wahoo who comes in and says, "Well, I've given 10 carpules and the patient's still not numb." And you say, "Oh, really?" But anyways, so I tend to use, I guess you'd call it a shotgun technique. I'm just going to go through a series of things because I want to move things along. So the first thing I tell students is vary the mandibular block objectively. So take something, periosteal or something, and just push the gingiva a little off the midline. If the patient jumps, you don't have a block for whatever reason. And students want to say, well, their lips numb. They have to be numb. Well, no, they're not. If you touch that, you don't even tell them you're doing it, you don't have a block. So you're going to have to repeat that, maybe with an alternate technique. I happen to like the Akinasi. But then I'll go through a series of other things. I'll just immediately supplement with some articaine infiltration over the apex, even posteriorly. I mean, that bone gets very thick, but I'll still do that, even back to the first molar area, certainly at least. I'll probably inject a little bit lingually in case you've got that aberrant mylohyoid innervation. And then I'll probably go right to PDL around the tooth and just go through that series. Usually by then, you can, again, maybe adding a little Bruticane, you can usually get that tooth out quickly. You have any thoughts on pearls on that?
I mean, my thoughts are mostly anecdotal, but for some reason I've found that a block with Septicane and then immediately after that another carpule of Marcaine on top of that for some reason is pretty powerful. The other thing, let's say it's the third molar or like a mandibular molar. If I can get them numb enough to start, drilling without or like troughing and sectioning a little bit without too much pain, if I can at least section real quick and get to the pulp and then inject into the pulp,
Yeah,
it's like a second or two right of pain when you hit the pulp.
right.
But if I could at least get there and then inject straight into the pulp, then now, yeah, I've got it full anesthesia there. But it
Yeah.
can be challenging.
And actually, I left that out of my shotgun technique, but if you have access to the pulp or you've created access, then certainly an intrapulpal will almost always do it.
Yeah.
One other little thing, if you've, and I don't know how much this is theory versus reality, but bupivacaine has the lowest pKa of any anesthetic. So if you've given a whole bunch of lidocaine with epi, so you've made that environment even more acidic, bupivacaine, at least in theory, might be good to try at that point, given its lower pKa.
Got it. And then how about the antidepressant drug classes and some of the contraindications that could exist there?
Yeah, I mean, people can get really crazy about this, and I just like to keep it simple because we've got four classes of antidepressants out there and a lot of patients that are on them. So we've got the tricyclics, the MAO inhibitors, and traditionally, when I was in dental school, we were taught you couldn't use epi with any patient on MAO inhibitors. Turns out that's not true. Then we've got the SSRIs, selective serotonin reuptake inhibitors, and the SNRIs, serotonin norepinephrine reuptake inhibitors. And I think with all of them, you think about limiting epi a little bit. The only true contraindication is with, and I don't know that anybody uses this or why they would use this, but the local anesthetics containing levonorepinephrine. So there's a product out there, bupivacaine with levonorepinephrine, which is a norepinephrine-like compound. Have you ever even used that?
No.
Yeah. And I don't know why anybody would, because it's just another intermediate acting local anesthetic. And we've got, most of the ones we use are in that category anyways. But that one, if anybody's using that, that's contraindication with the SNRIs and the tricyclics. But again, keep it simple. Why would you even have that in your armamentarium? Then you don't have to worry about the contraindication.
That makes sense. Okay, well that's helpful. Any other things that you do to I guess minimize the pain of the injection? I mean, like for example, I'm thinking if I'm infiltrating, let's say around tooth number 8 in the buccal vestibule, I was taught to like shake the lip with my left hand while I'm injecting with my right. We talked about the mirror pressure if you're doing the palatal injection. I mean, any other things like that that can kind of take the edge off?
I think that, just surgeons, we tend to be impatient, but if we've got a patient with naked local, we have to slow down a little bit and just be a little more mindful. So I do like a 30 gauge needle in the more potentially sensitive areas like the anterior maxilla. I'm not a lip shaker, but I know that can have a good effect as well. Always tell the patient that you're doing it. I always remember a case where a patient I had treated with local for many, many years was then transferred to a new associate who did the lip distraction technique very effectively. but didn't happen to tell this one patient. And so he injected the patient, left the room, and then the patient asked the assistant, "Does this doctor always shake that much?" So let him know you're doing it.
For sure.
Um,
Yep.
but yeah, I think just slowing down a little bit, realizing
Yeah.
this is not a sedated patient, use of a 30 gauge needle,
Mhm.
a little more careful
Topical.
technique, and topical. Yeah.
Yeah. And well, I think too, giving topical enough time to work. I feel like on the actual tube of topical, usually it says let it sit there. I think it says 10 minutes in most cases, and that seems like a ridiculous amount of time, but more than just 1 second, wipe it on. And I think too, if you dry the area with like a gauze first and then the topical is supposed to be
Right.
more effective. There's some nuances there, but giving it enough time, all that type of stuff, I think is
Yeah, I think, like you said, drying the area, just using a small amount is all you need, and 30 seconds is enough. I mean,
okay.
I think,
Excellent. Well, yeah, those are good tips and tricks. Any other thoughts on local?
oh, so we really didn't get to buffering so much.
Oh, yes.
So the concept itself is really not new. I've known plastic surgeons who have done it for years, just the DIY technique, which is kind of fraught with difficulties. You're really just guessing at the amount of bicarb and how effective that's going to be.
Yeah.
There is a product on the market called Onset. You familiar with that?
No, what is that?
So that's the one product that's out there. I think there were two. I think that's the one that remains. And basically, it's a device. So it's a separate device that you have to put the carpule in. So it means having an extra piece of equipment, couple extra steps. You have to put the carpule into the device, which then infuses bicarb through it. Then you have to use the carpule in a fairly timely manner. We all know the real benefits of buffering in terms of less pain on injection, to that point, faster onset, better nerve penetration. It's the all local anesthetics are acidic, but it's the free base that can penetrate the nerve. So if you make it more physiologic, that's going to help too. But again, back to Balance Pharma, and again, full disclosure, I am on the advisory board of that company. It's not a compensated position, but they have patented a standard carpule that sequesters the bicarb into one end of a standard dental carpule. They've done it for articaine and for lidocaine. So unlike that onset where you have to have a separate piece of equipment, you have to treat it with this product, which will probably be to market in about 2 years. You just pop the carpule in and you have buffered anesthetic that you'll be injecting. I think that's going to be a game changer. And to that point, Septidon just invested, I think it was 8 million into Balance Pharma. So, I think that's a
Oh,
show of support, and
yeah,
probably we'll be using those products within a couple of years. And
that's
that'll
great.
certainly be a much much more comfortable injection, as well as faster onset and probably more profound anesthesia.
Yeah, so kind of helping in multiple facets of the local.
Yeah.
That's great. Very cool. Well, cool stuff to look forward to. I love this topic. I think it's very critical for us. I mean, I mentioned this on the podcast before, but I think because we have the tool of sedation, oftentimes we maybe don't perfect the craft of doing local anesthesia or maybe don't give it its full, due attention. And so it's just a good topic to kind of review and say, well, what are the ways we can make this better? Because I'm sure most of us are still doing a large portion of just straight local cases per day. And
Yeah.
so it's important to know how to do this well.
Yeah. I agree.
Awesome. Last couple questions. Any good books you've been reading lately you'd like to recommend?
Okay, so two that I finished recently. One is called The Real Doctor Will See You Now. You familiar with that?
No.
It was written by well, he's now an attending at a Metropolitan New York hospital, but he basically wrote about his experience as an intern. It's pretty interesting. It's kind of like a modern day House of God. You know the book House of God? That was a classic
Yes, I read that and I
many,
loved it.
many, many years ago. Well, this is kind of a modern day version of that. That's pretty good. The other one that I finished is called Die with Zero. Author is Bill Perkins. And I actually bought the book after I heard him on a podcast, The Drive. Peter, you ever listen to The Drive, Peter Attia?
Yes. Yeah. I really enjoy him.
And you're doing so many yourself, you probably don't have
Hmm.
a lot of time listening to others, but he's great. He talks about longevity, health, what he calls medicine 3.0, which is, more proactive beyond just the standard care that we might get in a internist office in many cases. But I first heard him speak on Peter Attia, The Drive. Then I bought the book. The book was a little disappointing, so I guess rather than buying the book, search out that 2-hour podcast with Peter Attia and Bill Perkins, Die with Zero. The concept isn't new. Many have talked about that. And it doesn't mean that you spend everything, leave nothing for your children, nothing for, legacy giving, but maybe you do more while you're alive. He talks about not just worrying about net worth, but maybe thinking more about net fulfillment. So you do more while your kids are young adults when they probably need more cash infusion. Maybe you have more experiences with them, travel more, and just points out that it's hard for physicians, especially, and dentists and oral surgeons who are in that accumulation phase when it's come to time to unwind. It's hard for them to do, and many just die sitting on this huge nest egg, and that hasn't helped them and hasn't helped their kids, and it hasn't helped their legacy giving. So I thought that was pretty revealing. I guess I'd listen to the podcast more than get the book.
Nice. That's a great recommendation. I'll have to look that one up. Yeah, I read Peter Thiel's book Outlive, and that's a fantastic book. And
Yeah.
several have mentioned the book Die with Zero on the podcast as well. So I need to check that out. Any good shows? Do you even watch shows or movies?
I do. I haven't come across a great one really. I noticed there's a new season of White Lotus. I got a kick out of that one, so I might go back and watch the new season. Have you seen that one?
I haven't. I've heard a lot about it, but I haven't watched it yet.
Yeah, I think that's pretty good. Have you got a recommendation for me?
Not really. Mine are probably too cringy for you to watch. I,
Not
I don't know if
necessarily, Grant.
I don't know
I
if you've
got
heard
it.
of Cobra Kai, but I watched that with my kids, and it's pretty entertaining.
I
Cobra,
actually I did see that. I didn't see the latest, but I think I saw. Were there 3 seasons of that? I think I saw two. It was pretty good.
yeah, they just made a sixth one, the final one. I just loved the original Karate Kid, and so I like
Yeah.
seeing these guys, and there definitely are some pretty cheesy, predictable moments, but it's entertaining. And then there's another show because a lot of these shows I watch with my kids, but there's one called Young Sheldon on Netflix, and it's about this super smart kid growing up in Texas in the South in the 80s, and it's just absolutely hilarious. But each show has like a good message about it, so. Anyhow, nothing super profound, but those ones are good.
Actually, that reminds me of another one. Shrinking was pretty good.
Oh yes, I did see a lot of that.
Harrison
That,
Ford. Yeah,
that
that
was
was
great.
pretty
Yeah.
good.
Yep. One author I came across recently was, I don't know if you've heard of Stephen Pressfield, but he's a great author who talks he has he wrote The Legend of Bagger Vance and others, but he's put out a lot of books on writing, and I'm getting more into writing these days, and I'm doing some of my own book type of writing. But he has a couple of good ones, The Warrior Ethos, and tons of great writing books. I know you've written your own books as well.
Are you working on a novel?
No, it's more of a right now. I'd like to write a novel actually at some point, but I'm doing kind of a self-help book actually on kind of more geared towards surgeons and dentists for ways to help your spine and avoid back pain and neck pain and stuff like that. So kind of a boring topic, but
No,
interesting.
that's great. I mean, that's important, and I know your history with that. So
Yep.
you're the right one to write the book.
Yeah, writing a fiction novel to me just seems completely overwhelming. It seems like I would need so many more skills than I've got currently. What are your thoughts on that?
Well, I did a lot of mentoring. I took courses with some thriller writers, physicians. We may have mentioned this on the other podcast. That was quite a while ago, but I worked with Michael Palmer and Tess Gerritsen, who used to give courses to physicians who wanted to learn how to write fiction. So I learned a lot from them and read a lot of books. Their books a lot of books written on how to write novels. I think Elmore Leonard had one. He's a pretty well-known classic fiction writer. So yeah,
Nice.
I tried to really train in the craft before sitting down to do it.
Okay, excellent. Well, good. This has been really helpful for me. If you're good with putting your contact information in the show notes, I can put that in there in case listeners have further questions for you, and I'll put mine in there as well in case they want to reach out to me.
Of course, always.
But I appreciate taking the time to review this, and it's always awesome talking to you, Dean.
Thank you, Grant.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.